Welcome to the Neurofascial Release Conference. This conference is divided into two parts to give you some good ideas on palpatory skills to help with some of the patients in your practice. The first part is going to be involved with expanding your palpatory awareness to wind up strains throughout the body and use inherent body forces to release them. The second part of the course will be to help recruit inherent body forces and identify different kinds of strain phenomenon to release these strains. This course is not a substitute for the usual process of taking histories, performing physicals, and doing other diagnostic criteria that will be important to reach a therapeutic conclusion. We assume that all the patients who would use this approach in your practice are being treated according to your license. They have been evaluated medically, and that this is part of the care that has been decided to use for them. We make no physical diagnosis recommendations for any individual patient's care or consultation. Having said that, we will explore the applications of osteopathic manipulative treatments to a wide variety of interesting phenomena that we find in the body. I hope this program will give you some good ideas to use when you go back to your practices after having taken the course or having watched this video. Before getting to the principles and applications of those principles of osteopathy, I would like to say a few words about the founding of osteopathic medicine. Andrew Taylor Still, MD, was the originator of the osteopathic concept. He was a Civil War physician who studied the body as a piece of mechanical equipment, and from his 20 years of exploration, he developed the osteopathic approach. It is based on several principles. From these principles, all the treatment is developed. The first principle is that the rule of the artery is supreme. An organ must have correct blood flow to it to function normally. And to the degree that it doesn't function normally. The second principle is the interrelationship of structure and function. The body and its parts must be in related anatomical positions for that machine to function optimally. To the degree that it's not, the machine begins to function not so well until it gets to the point that we call disease. As osteopathic physicians, we have trained our hands to find these subtle malalignments and to normalize them. To the degree that they will have an influence upon the human mechanism is the degree that that patient will improve when we remove these strains. The third part, which is the one we rely upon most of all, is the inherent healing power of the body. Without it, all of our treatments would come to naught. So these three principles are the principles that we are going to apply throughout this course and see if we can make some changes in human physiology by normalizing structural, functional relationships. In this course, we're going to apply principles to parameters. The procedure will be to define a parameter, analyze that parameter, apply the principles we'll shortly describe, and then go back and see what has happened to our parameter. The procedure will be as follows. 1, we analyze our parameter. 2, we take our strain and recruit through the whole body to an end point. At that point, we're going to recruit our three little friends in the body that will help us make the correction. These are manifestations of the inherent healing power in the body. The first is the motion of the cranial mechanism. The second is the cardiovascular. And the third is the motion of the diaphragm, which as it moves in inhalation and exhalation, pulls all the fascial planes. We create a fulcrum against which all of these work to allow our correction to occur very quickly. So by way of demonstration and introduction, I'm going to show a release of the pelvis by holding and rotating the pelvis about a fixated spinous process of L5. Because these are gross motions, you'll be able to see the correction rather quickly. So I've chosen L5S1. The process is to find the spinous process of L5, find the end of the sacrum and a little soft area, which is the interspinous ligament, and finally you come to a little hard bump, which is L5. Then you're going to hold on to the ankles and you're going to raise at tissue speed. Now this means the rate at which the tissues will accept the forces that you apply to them based on their plastic and elastic properties. I'm not moving the legs like this. I'm going at the rate they will go until I hit an end feel. Now this end feel may feel like you're going into a ratchet, or you may be taking up slack, or become like a brick wall. That is a quality that we use to evaluate end fields. And in our range of motion evaluations, we apply the principles of how far does it go, how easily does it go, in what direction does it go, and what's the quality of that feel. Because when we make our changes, that's going to tell us how things have improved. So we raise the ankles at tissue speed, rotating the pelvis about an AP axis to an end feel. We imagine we have a goniometer, and we look at that angle created between the table and the ankles. Then we allow the legs to depress, and that gives us another measurement. While we're doing this, we're mindful of a quality called lifefulness in the tissues, and that tells us whether to do a direct or indirect action. And on this patient, when I bring him into depression, which is be it indirect action, there's a lifefulness that comes in the tissues that's not there during the elevation. So our body is telling us to make our correction in depression. I'm fixating here at L5, the pelvis is rotated, I add a little more tension to wind it into the rest of the body. And when I get the tension just correctly, we begin to see a change in respiration. The body goes into a still point. And then suddenly the tissues have relaxed. And we find as we move at tissue speed, there's an increase in the range of motion. Now in relatively healthy patients, this would be a good response. In severe arthritics, if you get 1 or 2 or 3 or 5 degrees, that's plenty. Don't push it any further than that. So let's review the procedure here. We have a parameter, which was the rotation of the pelvis about L5. We analyzed that parameter based on the degrees we found of elevation and depression of the leg with the table. We then took it in the direction of greatest lifefulness, which in this case was indirect, to an end feel. Then we wound it up through the rest of the body with a little more tension and allow the cranial, respiratory, and circulatory pressures to make our correction for us. We then went back and evaluated our ranges of motion based on the plasticity and elastic forces applied in that system.